Good afternoon, everybody, and thank you for joining us again for one of our wonderful specialist education seminars. Today we have the delightful Associate Professor Steve Flecknoe-Brown. He is going to talk to us about venous thromboembolic disease and its treatment. Now, this specialist has been with us for quite some time and is one of our favourites. And he's very well known in the medico-legal world. He writes an outstanding report. So if you ever need him, he is your man. And if you look at this man's list of credentials and experience, it reads like a who's who. The number of places where he has been the chairman of important research organisations, local government organisations, advisory councils and boards, and he's been instrumental in the education of new specialists within haematology. So pretty impressive guy. This is going to be a very good talk. Without further ado, over to you, Steve.
Well, thank you very much. I'm very flattered by that introduction, and I hope that you will see, at least in this talk, some of those claims on your behalf are supported. So we're talking about venous thromboembolic disease and its treatment. This has become a very important topic in haematology, and the good thing is that when I went rural 25 years ago, my involvement in those hot areas, the fast-moving areas like acute leukemia and so on, dropped off, and I was able to focus on things like thrombosis and its management, and iron deficiency and transfusion, things like that. So I've kept well abreast of this field, and was involved in one of the key studies that led to the approval of one of the newer oral anticoagulant agents a few years ago. It's like everything in haematology, it's very much evidence-driven, and it's actually not as difficult as some would think, although it is complex, and I'll try to make those complexities as easily managed as possible, as easily understood as possible. So go to the next. There we go. So I'm talking today. First of all, I'm going to fill you in on the mechanisms for those who either haven't given it some thought for a long time, or have found previous explanations a little complex. We'll talk about the diagnosis and treatment. We'll talk about that important question of how long treatment should continue. And then finally, the thrombophilic states. The thrombophilic states are, as the name would suggest if you look at it, the opposite of hemophilic. It's, in other words, they're conditions in which a person is constitutionally inclined to form clots at a far greater rate than everybody else. So first of all, mechanisms. Now, to start with, we all need to form clots. Clots are not the problem. Clots form a plug on an injured blood vessel, or injured blood vessels, in a situation where they are needed. And you only need to have seen the devastation of haemophilia, as I saw during my training, or the problem of a woman bleeding out after delivery, to see what the lack of ability to form clots can do. So we don't worry about clotting. It's when clotting gets out of control, when the clot propagates and moves into and blocks off the lumen, the inside of the vein, that you get venous thrombosis with its subsequent complications. So we'll talk about the commencement of clotting. We'll talk about Virchow's triad. Virchow's triad was named in honor of Rudolf Virchow, a pathologist from the early 1800s. he described all of these things, but he didn't actually name it Virchow's triad. It was named that about 20 or 30 years after his death. We'll talk about what normal, natural mechanisms are there to limit the propagation of the clot, and also another set of mechanisms that are there to trim the clot back to a reasonable size to do the job of sealing off the blood vessel, but not so large that it actually blocks the blood vessel and causes harm. At the end of this, you should have an irregularity in the surface of the vein, which then is invaded by fibrous connective tissue and resolves into a partial obstruction of the blood vessel. Ideally, if these clot trimming enzymes have done their job properly, it's only a small irregularity in the wall of the vein, which will eventually shrink down, as all scars do, until there's nothing to see. So the clot resolves by the attack of these clot trimming enzymes, and then what's left is invaded by scar tissue, which shrinks down the way scars do over the years. And in most circumstances, for most of us, a clot in proximity to a vein is left with no residual deficit at all. So this is normal clotting. As you can see on the illustration, the larger scale illustration, you can see that blood cells are escaping out of that little rent in the blood vessel, and as a result of that, there are a number of responses. Those spiky looking things are platelets, and platelets normally circulate in the blood system as small disc-shaped vessels, almost very comparable in fact to the shape of red blood cells, but much smaller. They're particles of cells, and that disc shape allows them to just slip around the blood the blood system, the blood circulation without any problem. But when they are activated by exposure of tissue underneath the blood vessels, the tissue that's been exposed when the blood vessel has been rent and the blood has been exposed to this tissue, they change shape and form that burr shape there, and that makes them fall out immediately out of the circulation. They also activate certain enzymes which make them stick together and form that plug that you can see between the inside of the vessel and the outside of the vessel, that creamy looking muck. Now that's just a temporary measure. It lasts for a few hours. In the meantime, those strands of creamy looking tissue that you see matting up the red cells and platelets, that's fibrin. That's an insoluble protein that has been formed by the polymerization of a soluble precursor called fibrinogen. So there really are several phases to the sealing of a blood vessel. The first phase is actually nothing to do with the blood. It's the muscles around the blood vessel. They spasm, and that sort of minimizes the size of the hole. The next phase is that platelet aggregation and forming a raft that plugs off the hole. And on the top of that is activation of the coagulation system. This is one of the reasons I object to the term blood thinners, because they all work in different ways. Aspirin works to stop platelets from aggregating, whereas anticoagulants work to either stop to remove activated clotting factors from the circulation so that propagation of the clot doesn't occur, or to slow down the formation of fibrin by slowing down the activation or the development of these various coagulation factors, which have an amplifying effect from a small trigger to a large number of activated clotting factors, which will form those strands of fibrin. Those strands of fibrin make a nice big plug to plug off the blood vessel fully, but then provided that the balance between the clot limiting enzymes and the clot promoting enzymes, provided that's retained, the clot doesn't propagate into the blood vessel. However, it can. And it can in the circumstances of Virchow's triad. In other words, if there is the first of these is stasis. Stasis is either a crimped or occluded vein that has a slowing down of the blood flow within that vessel, or actually stasis of the person themselves. If they're put to bed, their heart, the cardiac output slows down, the flow of blood around the vessels slows down. So if you've got the two occurring at the same place, such as a person sitting in a crimped up in an economy class seat in an aeroplane and just sitting there for 12 hours, for instance, you've got stasis that can promote thrombosis. Similarly, blood vessel injury is the second part of Virchow's triad. An injury to a blood vessel obviously promotes clotting, and that can in turn lead to thrombosis if the balance of factors is not proper. The third part of Virchow's triad is what he called sticky blood, but which we now recognise is blood which is more inclined to form clots. This could be from one of those constitutional conditions that I referred to earlier on, or it could be simple things like obesity, cigarette smoking, oral contraceptive pill. Of course, obesity also works by promoting stasis because they don't move as much and they get those squash sausage indentations at the joints. Obesity is an important promoter of thrombosis. So thrombosis is when the blood vessel, when the clot has occluded the entire blood vessel and indeed slowed down flow beyond that, which in turn tends to promote further propagation of the thrombosis up the blood vessel wall. And here is a nice illustration of the connection between the three. If the deep veins of the leg develop a thrombosis, in that middle cartoon, that thrombosis can at the friable end where it's just been formed, it's not been stabilized by the ingress of scar tissue and so on. The tip of the thrombosis that's waving in the vein can break off and embolize up the circulation. Now this is a thromboembolus. It's not a fatty embolus like you see in massive trauma, a lot of bone breaks. It's not an amniotic fluid embolus like you see in complications of pregnancy or delivery, and it's not an air embolus like we used to see when bottles were used to deliver intravenous fluids, and air came along the vessel when the bottle ran out and stopped the heart. This is a thromboembolus. So there are other forms of embolism, but for practical purposes, what we see most of by far is thromboembolus. And that embolus can travel up to will travel up to the heart, being drawn up by the venous return. It may travel through, it usually travels through the heart into the lungs, causing pulmonary embolus, but it can occasionally cross over to the arterial circulation if a person has a patent or a persistent opening of the foramen ovale between the two atrial chambers. And that causes a really perplexing situation, an arterial embolus, an arterial thromboembolus. So it's pulmonary embolism is the most common, but you just occasionally see, as I saw last week, an arterial embolus that has arisen from a venous thrombosis embolizing to the heart and crossing over to the arterial circulation, well, the left side of the heart, where it was pushed through the arterial circulation and causes an arterial thrombosis. Pretty scary, and much scarier than most pulmonary emboli, in fact. So, did I explain adequately the formation of thrombosis, the factors that promote the formation of thrombosis, and the way thrombosis can produce thromboembolism? I hope so. Let's now go on to the diagnosis. And the first way in which the diagnosis should arise is the clinical circumstances that give rise to suspicion that this might be a thrombosis or a pulmonary embolus. In other words, pain in the leg, swelling in one leg, not the other, in a patient who is, in a person who is immobile or who has had an injury to that limb. That's the sort of circumstances where you suspect deep vein thrombosis. Unfortunately, not all deep vein thrombosis in the lower limbs produce any signs or symptoms at all. Can be easily missed. The clinical circumstances that are a little more compelling are when a person with that background of at least in most cases, a background of immobility and injury to the lower limbs, or a recent overseas air trip, or a medical illness confining them to bed for a few days and having them a bit dry. Those are the background circumstances, and then they suddenly become short of breath, or they start coughing blood, or they develop pains in the chest. Those are much more compelling symptoms. And nowadays, but before I'm called to see these patients, I've usually already had a CT scan of the chest to see if they've got a pulmonary embolus. The level of awareness of this potentially lethal complication of thrombosis is rising, and that's a good thing. You then seek to confirm the diagnosis. Now, the D-dimer test is useful when it's useful when it's negative. The D-dimer test demonstrates the formation of a dimer of the D fragment of fibrinogen, which is split off when one molecule of fibrinogen joins onto the next molecule of fibrinogen to form that insoluble fibrin polymer that we saw illustrated in that cartoon earlier. So the presence of D-dimer in the circulation tells you that there is genesis of clotting going on, because bits of the D fragment of fibrinogen have been split off, and you can detect them in the circulation. Unfortunately, a positive D-dimer is not enough, because a positive D-dimer just says that there's some activation of coagulation going on, and it's not only thrombosis that can do that. Infection, other forms of inflammation certainly can involve the coagulation system and generate D-dimer. So if your index of suspicion is low, but you've got a positive D-dimer and there's no other explanation for it, that's good. That's a good reason to proceed further down the line of investigating. The gold standard test for demonstration of a venous thrombosis in the lower limbs these days is what's called a duplex Doppler ultrasound study. Very clever stuff, ultrasound. Ultrasound depends on sound waves coming back, and and those sound waves are at the high frequency ends. In fact, above the sound that we can hear with our ears. That's why it's called ultrasound. The advantage of using ultrasound is that the wavelength is very narrow. The sound waves are very close together. And so you can get very fine images of the soft tissues and the blood within them, and the various, and you can discern between various types of soft tissues depending on the textures that they return on the sound waves that bounce back and are picked up by the transducer. But that's an image. That's just an image that shows you if the vein has an obstruction in it that you shouldn't see. The clever thing about the duplex Doppler is that the other part of the duplex is a Doppler probe, which detects the difference in speed with which these sound waves are being reflected. And that relies on the Doppler phenomenon, which was originally, in fact, described in interstellar physics, where it was described as the red shift. A star moving away from you had a different color to a star moving towards you, and that's because the light waves were coming closer together. They had a higher frequency, and so they had a different color to the light waves going away from you. Now, of course, everybody's familiar with the Doppler phenomenon in sound. If you're sitting at a racetrack and you hear a race car come towards you, it's got a high-pitched scream, and then it goes as it goes past you. Similarly, an ambulance siren as it goes past you, it's going much more frequently on its way towards you than on its way away from you. And that's what the Doppler phenomenon shows you in ultrasound. The good thing about that is it tells you the flow. If you've got a visible obstruction on the image transducer accompanied by reduced or absent flow across that obstruction, you've got a DVT. In the case of pulmonary embolism, we use a CT pulmonary angiogram, abbreviated CTPA. The advantage of using a CT to get a pulmonary angiogram is that you can run them through that CT machine in 10 minutes. In fact, some of those very high-end CT scanners can do it in minutes. But you do it at the same time as you've injected a bolus of contrast, so that you can track the movement of contrast through the circulation around the heart and into the lungs. And that's the angiogram part. Very, very clever technology, and you can see areas where the contrast material has shown up, flowing blood, and you can see conversely areas where there is no movement of flowing blood, as demonstrated by the contrast material. So that is the gold standard now for the diagnosis of pulmonary embolism, as is duplex Doppler study for the diagnosis of venous thrombosis. I don't think we'll get any better than these. They are very reliable. Here's an illustration of a whopping great deep vein thrombosis. This woman had a thrombosis that went all the way up to the crease in the groin, and at that point, it was such a big thrombosis that it was beginning to jeopardize it was beginning to congest the circulation in her lower limb. And you can see from the difference in color as well as the difference in shape that she had a very big thrombosis and a lot of congestion of the blood flow in that limb. And this is a CT pulmonary angiogram, and you can see very cunning, very, very kindly provided arrows pointing to areas where the vessel, the end-on vessel round on the right side of that image, half of it is pale because of the contrast material, and half of it is dark because the contrast material is not getting in there. There's a clot there, and you can see that at several other places in this image. So that's a positive CT pulmonary angiogram demonstrating multiple pulmonary emboli. So treatment. I hope we now understand what should be done to diagnose deep vein thrombosis and pulmonary embolism, and the sort of things that make you suspect that you should be looking for it. Now we go on to treatment. The first thing is that I believe that if there's a large or multiple pulmonary emboli, that it's a good idea to go straight to a form of heparin. And for the purpose, I have very compelling evidence that the newer forms of heparin, such as Clexane, a name known to most of you, is more effective, both more effective and safer than the old-fashioned unfractionated heparin, even though there are pockets of resistance and people who are still saying, oh, we need to use heparin because we want to be able to reverse it. If unfractionated heparin was safer than Clexane, how come Clexane causes less bleeding than unfractionated heparin? It's as simple as that. So a form of heparin, whether the person chooses old-fashioned heparin or the newer form of heparin, of which Clexane is the most popular in Australia because it's the cleanest, is the best way to approach the initial management of a decent-sized pulmonary embolism or several pulmonary emboli. But after a couple of days, if you're sure the patient is stabilised, you can usually go to oral anticoagulants, and for the purpose, the direct-acting oral anticoagulants are by far the best. There are very few circumstances in which one can justify the use of good old-fashioned warfarin, otherwise known as rat poison, because it was used to poison rats. It's very effective for that, still is. But either at the beginning, in the case of a short segment leg thrombosis or a small subsegmental pulmonary embolus, you can go straight to the direct-acting oral anticoagulants, and they'll work within a couple of hours of starting them. Heparin works immediately as soon as it's in the circulation, and that's why I prefer that in a situation that might go bad. There are some situations in which a drug, again, some people would call this a blood thinner. It's not. It's an enzyme that dissolves clots. It actually directly dissolves the clots themselves, rather than depending on the naturally occurring clot dissolving substances, which have to be in excess of the clot promoting substances. But you can give now a manufactured form of a clot dissolving drug that will immediately dissolve the clot that's in the that's been lodged in the lung. There are a few circumstances, it's still a little bit controversial, but there are some circumstances in which it's definitely best to give a thrombolytic drug to break down that clot straight away and save the patient's life. I would also point out that there are occasions where you're saving the limb. In the case of a big thrombosis in the entire leg, such as, well, very similar to the one that you saw the image of. So thrombolysis, drugs that dissolve actively and immediately establish clots, has its place in the management of venous thromboembolic disease, even though that is a strictly defined place. I just saw recently, I haven't read it yet, but in the New England Journal that just came out today, there's a debate on the use of thrombolytics for submassive pulmonary emboli. We won't go into that. So the direct-acting oral anticoagulants are very effective. They're very safe compared to warfarin. They are more effective because you don't have this fluctuation in the effectiveness of the drug that can be affected by things like diet, things like other medications in the system. And that's why people on warfarin have to have these regular blood tests. You don't need to do that with direct-acting oral anticoagulants. If the patient takes the medication, it's working for the period of time until the next dose is due. One thing I'll mention, that last line, is probably one of the things that people complain about the most after a thrombosis. they may not know that they dodged a bullet in the form of a pulmonary embolus, but they will know that they have got shockingly, well, sometimes painful, but often just dragging feeling in the lower limbs. If that thrombosis didn't resolve properly and the vessels didn't reconnect properly. This can lead to significant damages in the skin, significant changes in the skin with staining and shedding of skin cells, what's called venous eczema, and it can lead to ulcer formation. It is a very unpleasant complication of a large thrombosis. It has an incidence of about 40% with full length thrombosis, and that incidence can be halved if the patient is instructed to wear full length compression stockings for 12 months after the episode of thrombosis. Halved. So that's certainly something worth doing, and it's certainly something which people will come to lawyers complaining about after the thrombosis. And the fact is, the risk could have been reduced if they'd had the recommended treatment. Of course, reduced, not abolished. So now we go on to the duration of treatment. And this is a subject of some nuance. A lot of my colleagues tend to have a formula of so many weeks or months for treatment. It's not as simple as that. It's not as simple as that. Firstly, you need to ask the question: was this provoked by an obvious factor, such as a long distance air flight, and it's more than 4 hours? Such as the oral contraceptive, but most commonly such as a multiple trauma or broken bone or hip fracture or joint replacement surgery. We also see it in association with pelvic surgery and chest surgery and so on, but the ones I mentioned were the most potent things that provoke thrombosis. And in those cases, you can say even 6 weeks can be enough if it's a short segment thrombosis below the knee. And there's a group of people who would say, no, just observe it with an ultrasound every week, and you only need to use anticoagulants if it's extending. But unfortunately, you know, there's enough studies to say now that anticoagulation is a better approach, because a number of people will extend, and the occasional one will get a pulmonary embolus. In the case of a provoked deep vein thrombosis that's full length in the lower limb, they need 6 months. In the case of a provoked pulmonary embolus, 6 to 12 months is the recommendation. On the other hand, if it's unprovoked, there is already compelling evidence that the risk of another pulmonary embolus is quite high, in the order of 25% if anticoagulation is ceased. So most of us nowadays are recommending lifelong anticoagulation if you cannot define a reason for provocation of that pulmonary embolus that you're treating. There is now some discussion coming on about whether unprovoked deep vein thrombosis also should be treated lifelong. And before ceasing, in any circumstances, whether it's provoked or unprovoked, before ceasing anticoagulants, it's a good idea to show that there is no ongoing thrombogenesis happening by doing a D-dimer test. And in fact, an Italian group demonstrated that if the D-dimer test is negative and you stop the anticoagulants, you get an even better prediction of the risk of further thrombosis if you repeat the D-dimer a month after ceasing the anticoagulants. If they're both negative, the chance of a recurrent thrombosis or another thrombosis is in the order of 3%. If it turns positive, it goes up to 19%. So that's the right way, the sophisticated way to decide whether it's safe to stop anticoagulants. Finally, how's our time going? Plenty? Good. These thrombophilic states are interesting because they do definitely increase the risk of a person having a thrombosis, although some of them are more dangerous than others. For instance, antithrombin 3 deficiency, AT3, or protein C deficiency are associated with a much higher risk of thrombosis. And a person with inherited antithrombin 3 deficiency is likely to get through their life without having a thrombosis. Protein C deficiency is associated with some pretty odd and pretty nasty thromboses. But there are also some inherited disorders, and we're probably going to. I last read an article suggesting that there are about 40 inherited conditions that can increase the risk of thrombosis, even though the big two are this one, factor V so-called Leiden mutation. It's called a mutation, but it occurs in 4.9% of Western population. So I call it a polymorphism. It's just part of our genetic diversity these days. And I think you're going to see the prothrombin gene mutation, again, probably a polymorphism because that's 3.8% of the Western population. So they're the common ones, but as the human genome, as the fruits of the Human Genome Project are harvested, we're finding more and more constitutional conditions that are associated with increased risk of thrombosis. And there are acquired conditions as well, and we mustn't forget them. The one that all the clever medical registrars think about first when you say thrombophilia is the phospholipid antibody syndrome. It's in fact the rarest, but it can be very nasty. It can be very nasty. It can promote arterial thrombosis as well as venous thrombosis, and it is resistant to it's resistant to that class of direct acting oral anticoagulants that I mentioned. This one needs the full power of warfarin to deal with it. So it's rare, but it's nasty. And myeloproliferative neoplasm, that's a condition in which the bone marrow is overactive. It's a malignant growth. It doesn't go away by itself, but it's not as nasty as leukemia in that it's producing mature formed cell elements. The commonest of them is polycythemia vera, that is an excess of red blood cells, which understandably makes the blood viscosity thicker and therefore promotes stasis, if you like, decreases the rate of flow around the circulation. A less common but obviously more pertinent one is essential thrombocythemia, which is where those platelets that I showed you in those cartoons are increased in numbers. And if the increase in platelet numbers is dramatic, it can certainly provoke thrombosis in its own right. I think that's your lot. Yes. So I shall stop sharing my screen.
Wow, that was really, really interesting and a little bit scary. Does anyone have any questions that they would like to ask? If you do, you can quickly unmute yourself and ask your question. No? All right. I have got some questions from people who were unable to attend. If you want to stop the share, just slide down to the bottom of your screen.
Just finding it. My apologies. I can't find it.
That's all right. Just leave it like that. Not a problem. So I had a quick question for you, and that was about the risks of putting a person on the lifelong anticoagulants. Obviously, they've got a condition which is indicating that. Otherwise, they're going to have more, thrombosis and potentially life-threatening. But what if that is their prognosis, that they have to be on anticoagulants for life, what are the risks? What are the side effects? What things can they and can't they do to manage that?
Good. Well, it's not a case of wrapping them in cotton wool. There is actually some very reliable. Well, there are some very reliable data, because there's now a large number of patients on oral anticoagulants for this heart arrhythmia called atrial fibrillation, and over hundreds of thousands of patient years exposure, it's clear that there is a difference in the risk of bleeding, clinically significant bleeding, depending on which anticoagulant they're on. The risk of bleeding, clinically significant bleeding, is in the order of 3.3% for the drug known as apixaban, 3.6% per year. This is, in other words, 33 bleeds per 1,000 people treated for 10 years. Is that right? No, per 1,000 people treated for a year. It's 3.6% for rivaroxaban and dabigatran, and good old warfarin, it's just over 4%. So there is a risk of bleeding, and that is intuitively obvious because, as I explained, we're deliberately slowing down the rate of clotting, and that comes at the cost of a few bleeds per year. When you're discussing this with a patient who's just had a nasty clot or a nasty pulmonary embolus, and it's explained that the risk of bleeding is there, but almost all of those bleeds can be dealt with and won't cause long-term disability, most of them will happily choose the anticoagulation. But I must say, it's a discussion that has to be had. It should be had. And unfortunately, a lot of the time it isn't.
Yes, that's it brings us onto a whole nother area, doesn't it? The other question I had is, does hemochromatosis increase the risk of a person having a thrombosis?
Good. The answer is no. Hemochromatosis is an iron storage problem. It's the problem of the iron, not the formed red blood cell elements that iron makes, that iron is necessary to form. So there's often a bit of confusion between the two. But in hemochromatosis, you got too much iron. The best way to get rid of that iron is to take blood off from time to time until you get the iron levels back into a normal, or in my opinion, lower range. There we are. And that's hemochromatosis. It is not a thrombogenic. It's not a thrombophilic state. On the other hand, if a person is carrying extra formed red blood cells because of this condition, polycythemia vera, then they are at risk of an increased risk of thrombosis. Different conditions, but easily confused.
Fantastic. Well, thank you so much for another really, really informative seminar. I certainly enjoyed that. Everybody, thank you for making time to join us today with Associate Professor Steve Flecknoe-Brown, the haematologist. The recording and slides will come to you within a day, and they will always, of course, be available up on our YouTube channel, and you can also watch any of the seminars that you may have missed on the YouTube channel. So we've got some really great ones coming up, and we look forward to seeing you for them. Thank you again for today, and have a great rest of the day.
Thank you very much. And I hope the absence of questions means that I answered or head off all the questions, but sometimes it means people are a bit shy. Oh, there's a question.
Oh, no, that's is that a question, Belinda, or just a thank
Belinda.
you? Looks like it's claps.
Oh, thank you. Oh, good
It was
idea.
a good seminar. I told you that.
Okay.
Excellent work. Thank you, everybody. See you later.
Thanks, everybody.